Okay. Okay, let's start. Yes.
Okay, sir. Good evening, all. So today we are going to discuss regarding cytokine release syndrome. So next slide. Like we are going to discuss now regarding what are we are going to discuss. So objectives like introduction, definition, causes, pathophysiology, clinical symptoms, and grades of cytokine release syndrome, and how we are going to manage. First is introduction. So, cytokine release syndrome is also known as a cytokine associated toxicity, and it is also called as storm syndrome. And it is a non-antigen specific toxicity that occurs as a result of high level immune activation. So, next we'll go for definition. So what cytokine release syndrome actually means? So it is a form of systemic inflammatory response syndrome that can be triggered by a variety of factors such as infection and certain drugs. So cytokine usually we can split it down like cyto means cells, so kinase means there will be synthesis, so cells will divide, and if any drugs, like example we can give for ATG also. So when we give injection ATG, so it is made up of rabbit antibody. So when we give it to a human, there will be a reaction between the immune system. So example, it means like that. So one more meaning, it refers to cytokine storm syndrome occurs when a large number of white blood cells are activated. So when white blood cells get activated, and it will release inflammatory cytokines, and which will turn and activate, and more it will release white blood cells. So causes, CRS occurs when large number of white blood cells, and including B cell, T cells, and natural killer cells, and macrophage. Macrophage, it means like engulfing of bacteria, and dendritic cells and monocytes are activated and release inflammatory cytokines. This can occur when immune system is fighting against the pathogen. So when a foreign body enters, so when our immune system will fight against to the foreign body, and cytokines are produced by immune cells, recruit more effector immune cells such as T cells and inflammatory monocytes. Next comes risk factors. So how it occurs, like early onset of CRS will be within 72 hours, and lymphodepletion with fludarabine based conditioning, and high infused CAR T cell dose, and in severe thrombocytopenia, and high baseline serum ferritin of about 1500 levels of ferritin level. So next comes pathophysiology. So pathophysiology, like how it will occurs and what are all the functions like it will takes place. So you can see the pictures, like first like in the there is a patient. So in patient, when he donates blood to get T cells, so in when we check in the lab, there will be infected virus like CARs, and CARs will get multiplied, and like when it multiplies, like the sterility and safety of the, it is important, and it will be infused to the patient, and these cells of cancer cells bind together, and this will start destroying the like immune system. So when foreign body enters, and the when our immune system get very faster than the foreign body, then it will be like more our own immune system can also destroy the own power what it has. It can destroy his own cells as well. So clinical symptoms, like how we can recognize CRS. So mainly like fever, like fatigue, loss of appetite, nausea, vomiting, diarrhea, rashes, and fast breathing, and hypotensions, and seizure. So next chart, like I have written like mainly how it is associated with CRS. So in organ wise, and with organ, how it like how we can recognize. So constitution, like fever we can recognize, and there will be tiredness, and there will be loss of appetite, that is anorexia, and there will be tiredness, and there will be muscle ache as well as, and arthralgia, nausea, vomiting, and headache. So in skin, we can visualize by seeing the patients as well. They'll be having rashes, and GI system like nausea, vomiting, and diarrhea. In respiratory, as we saw before, like there will be fast breathing and tachypnea, and there will be less oxygen, that is hypoxemia. In cardiovascular, like, there will be tachycardia, widened pulse pressure, hypotension, increased cardiac output, and potentially diminished cardiac output. Like in coagulation, we can see like elevated, that will be increased D dimer, and hypofibrinogemia and bleeding, and renal azotemia, and hepatic like transaminitis. So we can see elevated SGPT and hyperbilirubemia also. And neurological, like patient may have headache, like there will be mental status changes, and confusion, delirium, hallucination, tremors, and as well as the patient may go for seizure as well as. So great, next comes the grades of CRS.
Sorry.
No problem, sir.
Okay.
So grades, like we have total 5 grades. So grade 1, like it's like mild, like symptoms are like not life threatening, and requires, like based on the like clinical symptoms, we are going to manage the patient. Like if they have fever, we are going to give like antipyretics, nausea and vomiting, fatigue. Based on the clinical symptom, we are going to manage the patient. So grade 2, like symptoms requires, and there will be like moderate intervention, we have to act little faster, and oxygen requirement of 40%. And if the patient is hypotensive, responsive to fluids, we have to give fluids, and low dose of one vasopressor. And grade 2 may also lead to organ toxicity. Grade 3, symptoms requires response to aggressive intervention, and oxygen requirement of 40%, and hypotension requiring high dose of multiple vasopressor. And grade 3, organ toxicity, and grade 4, transaminitis. So grade 4 is like life-threatening symptoms. They require a ventilator support, and like it will also lead to the organ toxicity, including transaminitis. So grade 5, it is like if we have not treated it, it may go for death as well. So how we can prevent CRS? So severe CRS caused by some drugs can be prevented by using lower dose of infusing slowly. Like the medicines what we are giving, like ATG or any other medicines like what we are giving to treat. So it can be lower the doses, and we have to infuse it to the patient slowly, and administering antihistamines as well as. So we can give like chlorpheniramine injections and corticosteroids like hydrocortisone before and during the administration of the drug. So laboratory test and symptom monitoring. So how we are going to monitor, like how it can be identified. So like body temperature, as we have seen the clinical symptoms, so we have to monitor for body temperature, and respiratory rate, blood pressure, heart rate, oxygen levels, and neurological exam to watch for changes in brain and nervous system function. Laboratory tests such as blood counts, electrolytes, indicators of kidney and liver functions, cytokines, and other markers of immune function, and workup for infection. So supportive care and symptom management. Supportive care may includes, like if a patient go for hypertension, we have to manage it by giving IV fluids. And if they go for like hypoxemia, oxygen support or ventilator support may require medicines to be regulated according how the blood pressures are. We are going to escalate the antihypertensive, and medicines to support the heart function, blood product transfusion, as well as if the platelets or HP, if it's low, medicines or dialysis to support kidney function. prevention of seizure, as we have seen in the neurological clinical symptom, like we have to prevent how we can prevent from seizures. Patient at risk of for brain and nervous system effects may be given by a medication. So when if a patient get a seizure, such like we can go for medication called Keppra or levetiracetam to help and prevent the seizures that can occur with immunotherapy. Medicines to decrease the immune response. A common cytokine target is interleukin 6. The drugs most often used to interfere with interleukin 6 are called as tocilizumab and cilituximab. Corticosteroids such as methylprednisolone or dexamethasone may also be used to help reduce inflammatory and immune response. They do not target specific cytokines but rather provide broader immunosuppressant.
Okay, I think that's it, Kaveri.
Yes, sir.
Mhm. Okay, thank you very much. I want to just add that, so this cytokine release syndrome, we, in our practice, at least in India and Pakistan, we don't see it very often because it doesn't occur with match-related transplant that often. It can actually also occur in haploidentical transplant. We have seen it very rarely. In Bangalore, we saw it, for example, I don't know if you remember it, but with the patient from Morocco, El Hachimi. And what happens is that when you infuse partially compatible marrow, before you infuse post-transplant cyclophosphamide on day plus 3 plus 4, you can have a pretty massive activation of T cells, because these are incompatible transplant essentially. And then you can have cytokine release syndrome, like it occurred in this patient with hypotension, hypoxemia. So we gave him a little bit of steroids and he responded well. And most importantly, when we started cyclophosphamide, he got better because, of course, cyclophosphamide is destroying many of the activated lymphocytes. That's actually the whole point of giving post-transplant cyclophosphamide. So, and the reason why cytokine release syndrome has been included by JC and the fact in the core competencies for this advanced practice provider is that yes, the cytokine release syndrome is a very important, probably the most important side effect of this CAR T cell therapy, which has been shown by Kaverama, and essentially it is a gene modified T cell, which can be autologous or allogeneic, and it expresses a T cell receptor combined with the receptor for example, the most common is CD19, which recognizes leukemia, B-cell leukemia. And so we don't use CAR T cells because first we don't deal a lot with malignancies, and we don't, and also CAR T cells are extremely expensive, and so it's not commonly used in sort of resource limited settings. But in any case, of course, the APP have to be aware of this cytokine release syndrome. But we mostly see it, I would say, ATG, it can happen, but we've given ATG many times, and we don't normally see a severe cytokine release syndrome. Of course, the fever that we see with ATG, it is due to cytokine release, but not to the point that we need to treat it or is causing major problems. And then, as I said, we can see it in the haploidentical transplant situation before we give post-transplant cyclophosphamide, so on day +1 or +2. Okay, any other comments or questions?